Free webinar series from Archer Review. My name is Kiva Flodrovitz, for those of you who don't know me. And for those of you who do, welcome back. For those of you who are new to our webinar series, welcome. This is free and it's a webinar series that we like to provide to our APRN students, our nurse practitioner students, and we do a lot of different topics each week, and we have multiple webinars each week that we present on. So today we're going to be talking about diabetes. We did our first part of this lecture last week when we talked about just the pathophysiology of the glucose metabolism in the body, normal versus abnormal, and how to assess and diagnose diabetes. We'll do a quick review today, but the purpose of today is to really get into the pharmacology. So this is part 2 of that series. So welcome back for those of you who joined last week. For those of you who missed last week, I'll definitely make sure that I give you that information so you can go back and watch that as well. Before we get started, a few disclosures. We are accredited by the American Nurse Credentialing Center. So for this course, if you're participating through our Zoom account, you are going to receive 1 credit hour that's accredited by ANCC automatically if you stay for about 80% of the course, which is the hour. For those of you who have not participated through our Zoom account before and you're participating through Instagram or watching us on YouTube or our Facebook channel, it's okay. You could either switch now or just plan for next time when you join our webinar series to join through Zoom so that you get that contact hour as well. So that's a really nice offering that we have. We don't have any financial relationships with anything that I'm going to present today on the medication, pharmacology. This is just really taking the guidelines and building in what we know from clinical practice to help your clinical practice and your learning. So no commercial interests or financial relationships. Again, my name is Kiva Flodrovitz. So I'm a family nurse practitioner. I have been an NP for 10 years now. I've been in nursing since 2012. And I've practiced both in the primary care space as well as the endocrinology care space. So it's a really nice topic for me to talk about. Endocrinology and cardiology are my 2 big loves. So next week, I'm going to be doing a cardiac review. We're going to go a little bit into that today, just because with diabetes, it does increase your cardiac risk factors, and we'll talk about that. But I definitely want to make sure you guys understand the complexity of these diseases so that you can really better care for your patients. So that is my goal today. Our learning objectives really helping identify those common signs and symptoms of an abnormal glucose metabolism. So again, we're going to briefly talk about the assessment and diagnosis today. We go a lot more in depth on that, both in our on-demand videos and the webinar from last week. And then I want you to be able to walk away with being able to really assess patients, diagnose them, and manage them, right? Manage their abnormal glucose metabolism, including those diabetic patients. So that's our goal for today. And then also I want you to walk away with having the understanding of these pharmacologic interventions, most importantly for your clinical practice, as well as for those of you preparing for your boards exams, really knowing those potential side effects, educating your patients on those potential side effects. Also, huge thing to know are contraindications, that is safety, right? So we really want to talk about safety with these medications, and then those adverse reactions that we have to watch for, and again, educate our patients about. So those are our big bucket learning objectives that we're going to get into today. Before we really get into it, I like to use the Slido tool. So for those of you who joined in previous webinars, you know that I love my Slido tool. It's a really nice way to connect all of us on all these different platforms. I do still want you guys to participate on your platform. So if it's easier for you to respond in Instagram, or if it's easier for you to respond on the YouTube channel, that's okay. But this is also a really nice way because I did put together a case study for you guys. We ran out of time last week, so I integrated that case study into today. So I have a nice robust case study for you at the end of this webinar. And throughout the webinar, I'm going to also be quizzing you guys with our Q-Bank questions specifically about diabetic patients and managing those diabetic patients. So it's a really nice way to really make sure you're engaged and understand what I'm teaching you, and help solidify some of those concepts. So for those of you who've done Slido before, you know you can scan this QR code. and it'll take you to our first poll that is open today, so you can start participating. For those of you who have never joined on Slido before and you don't have the option of doing the QR code, you can also just go to slido.com and just put in the hashtag DMFarm, and it'll take you to that Slido poll that's open right now. And I always like to warm up with some openers of who's in the audience, because it gets me really understanding, do I have experienced RNs in the audience? Do I have NP students who are just starting out in their training? Do I have NP students who are getting ready to finish and getting ready to sit for their boards and enter clinical exam? It really helps me tailor today's webinar to you and helps create that classroom environment for us. So I really encourage you to hop on here and make sure that you're engaging with me today. And remember, your responses are completely anonymous. So all right, you guys, good morning. Good morning. Welcome, welcome. Happy Monday. You know, I just realized I'd started the webinar without starting Zoom, so you guys probably were not hearing me on Zoom, but those of you on maybe our YouTube channel and Instagram could hear it. So I'm going to start over this morning with going through everything I just said the first 5 minutes, because I didn't hit start webinar on Zoom. Silly me, Monday morning tech issues. Not surprising. We're all kind of trying to wake up from the weekend, right? I hope you guys had a wonderful weekend. We had awesome weather here in Texas. It was fantastic. It was like spring or fall in the 70s. So I was able to get out with my family and enjoy Father's Day. So that was really nice. I hope you guys had a lovely weekend as well. For those of you who don't know me, my name is Hiva Kolodrovitz. I'm a family nurse practitioner. I've been in practice for 10 years now as an NP, both in that primary care space as well as the endocrinology care space. And endocrinology and cardiology are my two loves, and they really go hand in hand. So we'll talk a little bit about that today. In today's webinar, we're going to focus on diabetes, specifically on the pharmacologic interventions and drug options for our diabetic patients. If you missed last week's webinar, I talked about the assessment and diagnosis of diabetes. We'll do a brief overview of that in today's webinar as well. But today is really all about pharmacology. Before we dive in, I want to let you know that this webinar is eligible for contact hours. So for those of you who are joining us on Zoom, if you stay for the full webinar, about 80% of it, which is the hour, you will automatically receive that full contact hour as an email. For those of you who are joining through other platforms, through our Instagram page or YouTube or Facebook page, just remember you can always switch over to Zoom. If you don't have the ability to do that today, you can just plan for it ahead of time next time. So don't fret, you'll still get all the content, but if you want that contact hour, then you will have to join through our Zoom account. Before we dive in, I have no financial relationships or no commercial interest in anything that I'm going to share with you guys today, really just taking the guidelines and applying them to our clinical practice. Learning objectives today. Again, I focused last week on that assessment diagnosis piece, but I do want to do a quick overview, make sure we're all on the same page before we dive into the pharmacology, because once we know the pathophysiology, the pharmacology makes a lot more sense. So we're going to quickly make sure you guys can identify those common signs and symptoms of abnormal glucose metabolism, be able to diagnose your patients, and then be able to manage your patients, right? Talking about those assessment and management strategies to really take good care of our patients that have abnormal glucose metabolism, our diabetic patients. And then I really want to focus on understanding, having you walk away with demonstrating understanding of those pharmacologic interventions, especially those safety protocols, right? So making sure you understand the potential side effects of those drug classes, you're educating your patients on those potential side effects, you are watching for those contraindications and you're safely prescribing, and you're also watching for those potential adverse reactions and intervening when necessary. So those are going to be our big buckets of focus today. A lot of great content to get through. Before we dive in, I always like to start off with our lovely Slido poll that helps connect all of us from all these different platforms. So for those of you who've used Slido before, you know you can scan this QR code and you can go in and put in your response to this first poll of who's in the audience today. And I see some people are starting to participate, which is great. As you can see, participation is totally anonymous unless you want to put your name in there. So don't be afraid to participate. I do have a great case study for you guys today. We ran out of time last week to do our case study, so I integrated that into today's webinar. So we're going to go through a nice robust case study to really assess, diagnose our patient, and then talk about treatment plan and what that management piece looks like. So for those of you who can't scan the QR code, you can always go to slido.com and put in the hashtag DMPharm. And all this is free and all of it is anonymous. It's just a nice way for me to understand who's in the audience. Are you an experienced RN? Are you a novice NP, or just starting your NP training, or just finishing your NP training? It really helps me tailor my webinar to the audience. So I really encourage you guys to participate, and you can either do it in Slido here or in your particular channels that you are participating in. I'll try to be mindful about looking at the other channels as well. So here, I just want to know who's in the audience. So tell me where you are in your nursing journey. Where are you in your training? I see an LPN student, which is really great. Good for you for participating today. This is going to be really rich, robust information. Maybe you're considering NP school. You're considering going back and going through the RN training piece. I see an experienced RN in here. Welcome, welcome. Some RNs, some FNPs that are already practicing. I'd love to know, are you early in your practice? Are you later in your practice, somewhere in between? And then I see NP post-grad, NPs, lots of NPs in the audience today. And from Connecticut, retaking. I'm guessing you're retaking your boards exams. Good morning, Malin. How are you today? It's one of my students. Great to see you on here. FNP studying for boards. So this is great. So we have kind of everyone from all over the place. So we have some FNPs, we have some FNP students or NP students, and then we have some experienced RNs and some LPNs. So this is a really nice, diverse population or student population. This is really great. Welcome, everyone. And I want to know, for those of you who are planning on taking your boards exams, if you're studying, we don't have as many in the audience. We have a couple studying for their boards. If you are studying this week, what is on your study plan? So is diabetes on your study plan? How do you feel about endocrinology? What sections really trip you up? I'd love to know. What are you focusing on this week? Is diabetes, pharmacology what you're focusing on this week? And this is just very timely. You let me know. What do you guys think? What are you focusing on this week? This also gives me a good sense of webinars to put on the calendar for you guys. So I always like to know, what are people focusing on? Pharmacology as a whole. Yes, it's very intimidating at first, right? Especially when you haven't had that experience to be out there and practicing and prescribing. I remember I was in my first NP role, just sweating every day. It just was a lot, right? Very scary. Psych pharmacology, beautiful. Cardiac, respiratory, GI. Yes, you're hitting all those main body systems. Awesome job. A lot of psych now in primary care, just because we don't have the access to care for our patients. So primary care is doing a lot of psych management, right? Very good, you guys. All right. And then my fluid and electrolytes. Okay. I wonder if that's our LPN there. Welcome. And then, whoop, did I miss my poll? Did I misnumber them? Let me quickly see what I did here. Okay, I think I misnumbered them. So let's keep going. Let's go into the content. All right, you guys. So quick overview from last week, just to make sure that everyone's on the same page. Remember, we are going to be focusing on our main two types of diabetes. So diabetes is chronically elevated blood glucose levels. We have type 1 and type 2 as our two main types of diabetes. Type 1 is going to be more of your autoimmune response, because what's happening in type 1 is that body is mistaking those beta cells in the pancreas for invaders. So it's actually breaking down those beta cells and destroying those beta cells. And those beta cells are what produce the insulin, right? So if that patient's body no longer has any functioning beta cells or very few functioning beta cells, they're not going to be able to produce the insulin that's necessary to help move this glucose from the bloodstream and into the cells where it's needed. So in our type 1 diabetics, they are dependent on insulin because their body's just not producing it. And this is an autoimmune response. We're going to see this in about 10% of our cases, and typically we'll see this more in early childhood. So it can peak between ages of 4 to 6, which is so young, right? I have a 6-year-old, and just thinking about a 4 to 6-year-old really being able to grasp this diagnosis and be able to grasp the management that goes into administering insulin to their body and their parents and their caregivers and what all that entails, it's a lot, right? Our type 1 diabetics need a lot of support, and we'll talk a little bit about that. But typically when you're thinking type 1, I want you to be thinking about really early childhood or early puberty, so before the age of 10. We are seeing a lot more in our older adult patient population with those type 2s, and I'll talk about that in a minute. But type 2 is really going to be more of that metabolic dysfunction. So in these patients, their body just has a lot of insulin resistance, right? And we're seeing a lot of fat kind of building up on those cells. There's a lock and key mechanism that really has to work with the insulin and the glucose getting into the cell. And they're having a lot of issues with that lock and key mechanism. So we're seeing a lot of insulin resistance. And then we're seeing insulin deficiency over time because what happens is that pancreas is just working in overdrive. It's just trying to produce all that insulin because it's detecting, the body's detecting that there's just so much glucose in that bloodstream. And it's saying, hey, we need to pump out more insulin to move some of this glucose into the cells. This is too much. And so the pancreas is really working in overdrive. And what happens over time is it gets pancreatic fatigue. And so this is what I'm talking about. We're seeing kind of our older patients acting more like type 1s because their pancreas actually is not producing as much insulin anymore as it used to because it's just so tired. So that pancreatic fatigue is causing them to act more like type 1s, right? But this is going to be the majority of the cases that you're going to see in primary care, about 90% of your cases. And 90% of the cases you'll be managing unless you go into a specialty like endocrinology. So that's really what we're going to be talking about and focusing on today. But I do want to still go over the insulins with you too, because that is part of your scope of practice. Now, when we're talking about signs and symptoms, this is a little poll that I had. But what do you think about these signs and symptoms? So I think a lot of people know the phrases, right? They know polyuria, polydipsia, polyphagia. But what are we thinking about in terms of pathophysiology? Would you see these signs and symptoms in patients that are type 1 or type 2 or both? So what do you guys think? And I see a couple people are responding, but what do we think about these signs and symptoms? And we talked a lot about this last week. I'll cover this a little bit today. But what do we think? Do we think we're going to see it in both? We're going to see it just in one? Most people think both. Okay. Either you guys watched my webinar last week or there's no tricking you guys. You guys are awesome. You know exactly what I'm talking about. You're going to see it in both, right? Because diabetes is diabetes. These signs and symptoms are your body's way of trying to really maintain homeostasis and dump some of that high glucose out of the bloodstream. So increased urination is really going to act and impact those kidneys, right? That's why with our diabetics, we really want to watch their kidneys because their kidneys are working hard. They're trying to dump that glucose through the urine. With it goes the water molecules. So they're going to get increasingly thirsty as well, especially with our newer type 1 diabetics. When we diagnose them, they're drinking a lot of water. You'll get that in the history too. They're drinking a lot more water noticeably. I still remember one patient, newly type 1 diabetic due to his cancer treatment, and he was just chugging water all day, every day. It was noticeable for him. And that was a particularly, that was a specific situation, but you really will want to be asking these questions, right? The thrush, the genital itching. So with that glucose, nice, dark, warm area where the bacteria and the flora really changes. So all that yeast feeds on the sugar. Same with the wound healing, so delayed wound healing, because again, the bacteria in the wound really feasts on that sugar. So you're going to have delayed wound healing and have a lot more incidence of thrush and genital itching and yeast infections. Blurred vision is really interesting to me because it's not just retinopathy that we're talking about. It's actually more glucose buildup on the front of that lens of those patients. So that's always been really interesting to me. So patients will talk about blurry vision, also fatigue, tiredness. So if the body's not getting the glucose that it needs into the cells, it can't produce ATP, it can't get the energy that it needs. So those patients are going to be increasingly fatigued. The body's going to try to break down its fat reserves because it's saying these cells need energy. So initially we'll see some weight loss, or with my patients who are really poorly controlled diabetics, I'll see some weight loss with them, right? And that always worries me because I think, okay, how bad are our blood sugars? Let's take a look at your log. And then that increased hunger, again, the body's trying to feed those cells. So with the weight loss, with the hunger, it's really trying to get the glucose into those cells that are deprived right now. So if that's kind of too high overview, I really want to bring your attention to our on-demand video. So we have over 16 hours of content. The endocrinology section itself, I think, is over an hour and a half, and it's really broken down to bite sizes. So you can go and just watch the diabetes section, but it goes in depth about the pathophysiology and what I just went over in a really high level. And the reason to know that is when you get into the pharmacology, you really have to know the pathophysiology, or then you're just memorizing. And we all know memorization is not going to help us long term. We also are going to be pulling questions from that Q bank today. So I'm going to be pulling questions from our Q bank specifically and give you a little taste of what that looks like. But if you missed last week's webinar and you want to join our community on the Facebook group that we have that's private, all these webinars are also published there. So it's really, really nice for you to be a part of that community. Annie, who does all our social media right now, is publishing a lot of case studies on there. So it's a really nice community to be a part of. I know some people don't like Facebook or don't use Facebook, but if you use it just for work purposes or study purposes, I think it's worth it. All right, so let's get into the pharmacology today. So we know that hemoglobin A1C is one way to diagnose our patients. So normal hemoglobin A1C is less than 5.7%. This is the average of the patient's blood glucose of the last 3 months. We do have our little pre-diabetic range, which is one area that I'm really passionate about working with our patients on to help prevent diabetes. And then once we get over that 6.5% range, we are technically in that diabetic range. We really have a lot of insulin resistance and deficiency, right? And so what is our goal? Let's see if I can go to my next poll, you guys. What is our goal A1C for our type 2 diabetic patients if they're healthy and under 60? So what is our goal A1C? And I like to talk about this when we're talking about management, because oftentimes I'll have patients who are getting above the age of 60 and maybe have some other comorbid conditions, and they're still fixated on these A1C goals. So I want to talk about that in management today, because you as the clinician should be looking at their pharmacology at every visit and making sure we are taking medications off as our patients are aging so that they're not experiencing polypharmacy and potential side effects and adverse reactions of these medications in these classes that we're going to talk about. So less than 6.5%, a lot of you are saying, and you guys would be right. So absolutely, we want to, the ADA says our goal is to really have our patients be under 7% for those healthier type 2 diabetics who are under the age of 60. So with our management, remember, non-pharmacologic management is always our first line. We want to talk to patients about lifestyle, making sure we're talking to them about their diet, their exercise, weight loss. Weight gain is a huge risk factor for metabolic syndrome, for diabetes, for impaired glucose tolerance. So weight loss really helps our patients a lot, helps our diabetic patients, our type 2 diabetic patients. We really want to talk to them about their exercise and their diet. Our goal A1C is really less than 7% in that healthy population. But as our patients start getting older, in our elderly patient population, I want you to start relaxing those goals for your patient, right? Because it is our job to really talk to them about what they need and what they don't need. And some patients will be thrilled because those medications are expensive, and some patients will be really scared because they will have had a long time of trying to get their A1C under 7%, and it's going to be hard for them to understand that now it's actually they're going to be at higher risk for complication if we continue to be as aggressive with their A1C than for complication with continuing chronically elevated blood glucose levels. Pharmacologic intervention, metformin always going to be our first line for pharmacology unless otherwise contraindicated, and we'll talk about that. And then our secondary drug classes really are going to be added on based on a case by case scenario with your patients. And I think that's what makes diabetes so complicated and so intimidating to new prescribers, because there are a lot of different drug classes and everyone's like, well, which one do I go with for the second line? And so you really have to be comfortable with the different drug classes and why you would implement one versus another for your patients and when. And we're going to talk about when to refer, but my take on it, especially being on the specialty side, is you can never go wrong with referring. Referrals always take a long time, but if you have a patient that you just cannot get their A1C to goal and you've tried a lot of different drug classes or they're non-compliant, it's not a bad idea to send them out to endocrinology, because endocrinology has a lot more resources. We typically have a diabetes educator on staff that the patients can see that can really help with that diet piece that you just don't have time for in primary care. And those patients really can receive more benefits on their medications as well, because typically those offices also do have those medications and can give them some samples and some supplies and help them with their insurance, and as well to make sure that they're getting their medication so that they could be using their medication. So it's, if you're ever having a hard time with a patient, I want you to be thinking, okay, maybe it's time to start that referral process and co-manage these patients. You're their primary care, but they also see endocrinology and cardiology. So let's get into those anti-diabetic medications. What is your comfort level? And this is a nice poll for me because I'm going to launch this poll at the end of our webinar too. And it really helps me gauge my teaching style and effectiveness as a teacher, as an educator, to make sure that you guys are gaining something from this webinar. It also helps us maintain our accreditation so that we can show that our webinars, our content are enriching and enhancing your learning. So if you can take a few minutes and just tell me, what is your comfort level with prescribing and managing these anti-diabetic medications? And again, this is anonymous, so please don't feel bad about being on one end of the spectrum or the other or right in the middle. I just want to see where the audience is today. Okay, we've got majority of the people are kind of right in the middle. I have one person in this 10 range. I love that. Definitely shoot me a chat. Love to hear what setting you work in. A couple people in that 9 to 10 range. All right, shoot me a little message. I want to hear what setting you guys work in. Do you work in endocrinology? Have you had experience? Are you diabetics yourself? Love to see that. But the majority of us are really in that middle range, which is okay. My goal is to really get everyone to that 9 to 10 range by the end of the webinar. So awesome. Thank you for participating in that. So as most of you already know, the guidelines that we really follow are the American Diabetes Association, the ADA. I also really like the American Association of Clinical Endocrinology, ACE. ACE does a really nice job with publications, and they do a really great job with the guidelines and really helping clinicians be able to decide what we want to do with certain drug classes in our patient population. Let's talk about sulfonylureas. This is the oldest class of medication. It's still the cheapest. It is falling out of favor due to the side effect profile. However, some patient populations still have to use sulfonylureas. Some clinicians have to still prescribe sulfonylureas because of the patient population they work with. Either they're uninsured or their insurance plans don't cover very much for their medication. So you may still be prescribing some sulfonylureas for your patient population. But let's talk about this drug class and why we are trying to steer away from sulfonylureas. This is the drug class that ends with the suffix "ide." So you have your glyburide, glimepiride, glimepiride. And once you're in clinical practice, you'll get more used to whether you like the generic name or the brand name. On the boards exams, they'll give you both. So you don't have to worry about that for those of you who are sitting for your boards or studying for your boards. Let's talk about the pharmacology of sulfonylureas. So they really increase the release of insulin from those beta cells. So when you think about that, it's going to be more obvious to you why it's contraindicated in our type 1 diabetics, because if those patients don't have those beta cells, then we can't give them a medication that's going to increase the release of insulin from those beta cells, right? It just won't be effective. So in this class of medication, it's contraindicated in our type 1 diabetics. And the biggest side effect, so what happens when you're getting an increase in release of that insulin? You're going to get more insulin in the bloodstream to move that glucose into the cells. So the biggest side effect with this drug class is going to be hypoglycemia, right? So they all kind of play a hand in what's happening. So if you understand the pharmacology, then you're going to understand the side effects and the contraindications. Now, weight gain is another one with this class of medication, and something to think about, because remember we talked about weight loss is really going to help our patients reach their A1C goals and really help with that insulin resistance. So when we have patients that are already struggling with their weight, maybe this class of medication is not the best to prescribe them because they do experience some weight gain with sulfonylureas. And you might get some questions like that on the boards if a patient's considering they're type 2 diabetic and they really want your help, pharmacologic intervention with weight loss. This is not the class of medication to recommend because it is going to increase that insulin release, which does get the glucose into the cells. If the cells get more glucose than they need, they start storing it into adipose tissue. So the patients do experience weight gain with this drug class. So really thinking about it that way is going to be really helpful. But that is the most important thing about the sulfonylureas. It increases that insulin sensitivity and really decreases that glucagon secretion as well. Last week, we talked about the liver and how that plays a role in maintaining the homeostasis as well, but definitely something to note about with sulfonylureas. Well, for dosing, you don't have to necessarily know specific dosing because these are things that you're going to look up in clinical practice. So anything you can look up is not really something that the board's exams typically likes to focus on. They're really focusing on that clinical decision making. But for you as a clinician entering clinical practice, just know that you really need to educate your patients on not skipping meals when they're taking sulfonylureas and taking this with that first bite because of that hypoglycemic side effect. And then we want to be really gradual about titration, right? We want to start really low with these medications, see how our patients do, and slowly increase them so that we're avoiding that hypoglycemic risk. All right, with TZDs, so this is the suffix glitazone. So you have your Avandia and Actos. I'm more used to using the TZD acronym and also the brand name with these medications just because the other ones are so hard to pronounce. And you'll get with, like I said, when you're in clinical practice, you'll get your comfort level with them as well. Pharmacology with this class of medication really does increase the body's reaction and sensitivity to the insulin. And one of the biggest side effects with this class of medication is that increased reabsorption of water through the kidneys. So remember, in diabetes in general, the kidneys get hit pretty hard. With TZDs, it acts predominantly through the kidneys and helps with that reabsorption of water so that we're not dumping all that water out. With that fluid reabsorption, we really get a lot of fluid retention. And so that is why contraindicated in our heart failure patients, especially our class 2 through class 4, because fluid with our heart failure patients, and we'll talk about this in our cardiology review next week, we really are watching those fluid levels and we're not trying to overload that heart. So with these patients, totally contraindicated, and you really want to make sure you're watching for signs of heart failure and counseling your patient for those signs and symptoms. They need to tell you right away if they are developing any of those signs and symptoms. But that fluid retention, with that fluid retention comes weight gain. So we're talking about that again because we really want to talk to our patients about weight gain, weight loss, especially our diabetic patients. But there is, with this class of medication, again, some associated weight gain with that fluid retention. But biggest takeaway with TZDs is acts through the kidneys predominantly and really contraindicated in our heart failure patients, and counseling our patients on those signs and symptoms of heart failure to make sure that we're stopping the medication right away if they start developing any of those signs and symptoms because of the pharmacology and the way it acts in the body. With this class of medication, it does have a long half-life, so it takes a while before it reaches its max effect. So you really, again, want to be slow with the titration. This is really maybe every 4 to 12 weeks for adjustments. So always, good rule of thumb, start low, go slow. But with this class of medication, you really want to go slow. You want to give it some time for it to reach that max effect before we're increasing the dose. And then last thing with this class of medication is that risk of osteoporosis as well. So we want to be mindful of that in certain patient populations. With our biguanides, we only have one drug currently in this class. We used to have 2, fenformin, but now it's just metformin. Fenformin was discontinued because of its strong association with lactic acidosis. Metformin is one of my favorite medications for our diabetic patients. It's also our first line in our type 2s unless contraindicated. And the reason for that is because its safety profile is really great. So metformin really works on a intracellular level, meaning that it helps really increase that uptake of glucose on those cells, on that peripheral tissue. So I really love metformin. It continues to work even after patients have stopped taking it. So if patients have been consistently taking it for 3 to 6 months, a year, and then they stop taking it, it continues to work for quite a few months because it really helps with that insulin resistance. So this is a really great drug class, and I highly encourage you to convince your patients to stick it out in those first couple of months with those GI symptoms where we really do expect that. We expect the upset stomach and the nausea. And what I usually do is I make sure I start low. So I do see some clinicians starting at that max dose for metformin, and I really encourage you not to do that because your patients will have a lot of GI side effects. They'll hate you, they'll hate metformin, and they will never take it again. No matter what you do or no matter what other clinician comes in and says, please, metformin's great, don't discount metformin, they won't do it. So really start off with that 500 milligram daily with the extended release. It also has a little bit better side effect profile, GI side effect profile. And I always tell my patients, take it with your biggest meal. So do they tend to eat a big dinner? Do they tend to eat a big lunch? When's their biggest meal, and take it with that. That really does help with those GI side effects, but what they can expect is a little bit of an upset stomach, some nausea, and some loose stools for a couple weeks. Keep them on the 500 for a couple weeks. It's okay. You don't need to go up to the max right away. I rather stay on 500 for even a month, have my patient come back in, and then we gradually go up to 1,000, because then the patient feels confident about it, their body's adjusting to it, and they're more likely to stick with it. So this is a really good drug class, and I really encourage you to go low and slow with your patients on this drug class. It also, the reason for that GI side effect, and I skipped over this and I apologize, it's because of that decreased absorption of glucose in the intestine. So that's really the way that it's working. And that's why we get those loose stools, we get the nausea. So it's not an uncommon finding, but it does get better if the patient sticks it out. So that's really, really important. And then it also acts in the liver, so it reduces that hepatic output of glucose as well. So contraindications, we really, in patients with severe hepatic dysfunction, this is a big no-no because we really want to make sure that they're able to clear it so we can avoid that lactic acidosis. So if they have any end-stage renal disease or severe liver dysfunction, this is going to be a big contraindication, big no-no for this patient because we really want them to be able to clear it so that they're not building up that lactic acidosis. All right, you guys, so let's go to our first practice question. We're going to go to poll 6. All right. So first question, in planning pharmacologic intervention in our geriatric patient with diabetes, which of the following should be considered A, B, C, or D? What do you guys think? Are you going to start this patient on a sulfonylurea, like a glipizide as your first line therapy? Are you going to start them on insulin as first line, combination of glipizide and metformin, or single medication metformin? So in the boards exams, for those of you who are getting ready to take either the ANCC or ANP, they really try to mimic what you're going to see in primary care. And the majority of our patient population is going to be adult patients and now geriatric, right? So a lot of geriatric in our primary care practice. So I want you to also focus your studying on your geriatric patients for those of you who are getting ready to sit for your boards exam. So what do you guys think? In a geriatric patient, and all they tell you is they're diabetic, what should be your first line? So you're newly diagnosing them. What is your first line recommendation for this patient? And the reason why I bring this up is because I actually see a lot of students telling me a few different things. And I want to make sure you guys understand that metformin is not contraindicated in our geriatric patients. So absolutely still first line unless they have advanced renal disease or hepatic disease. D is the right answer. Metformin is still going to be our first line in these patients. Again, that side effect profile is really great. So this is still our first line. Now, we would never start them with a combination. I see some clinicians doing this too. Some newer clinicians are like, oh, your A1C is so high. Let's start with the metformin. And then I'm also going to start you on a sulfonylurea. You never want to start with a combination, whether it's diabetes, hypertension, whatever it is, because you want to make sure that you are monitoring that patient for side effects. And if you start on two different drug classes, you don't know which drug class is causing that side effect, right? So you never want to start with a combination. You always want to start with a single medication, single drug class. And then that sulfonylurea, especially in our geriatric patients, we really do want to avoid this drug class in our geriatric patient. That hypoglycemic risk is huge, especially with our geriatric patients. We don't want them becoming hypoglycemic, falling, and getting themselves into worse trouble in that sense. And then it's funny because I do see a lot of patients saying that they would start the geriatric patients on insulin first, feeling like, okay, Lantus is a pretty safe choice. It's a basal insulin, it's long acting. I'm going to start them on insulin. So again, we worry about that hypoglycemic risk with insulin. So we are not going to be, that is never going to be my first line therapy unless patients are really coming from the hospital. They've been in DKA, they've started them on insulin to really get them under better control. This in outpatients never going to be our first line. So here are the explanations we just talked through. And again, these questions are coming straight from our Q Bank. So if you guys take our Q Bank questions, it'll link you to those on-demand videos as well. So if it's an area that you're just like, wait, I missed all of that, I need to go back and review that, it links the questions, give you the full rationale, gives you additional information that I couldn't fit on this slide today, as well as those videos that you can go back and watch and really learn that content because it's helping you identify a knowledge gap that you need to go back and fill. The nice thing about practice questions is a lot of people think, okay, I'm going to study the content first and then go and take the practice questions once I've studied everything. You actually learn as you're going with the practice questions. So research shows that you should be doing practice questions as you're studying the material because that really helps you learn the material better and faster and more efficiently. So wanted to throw that out there for you guys. We have some nice lunch and learns here at Archer, and that was one of the things that they shared with us as educators, and I want to make sure that I share that with my students. All right, let's talk about SGLT2 inhibitors. You guys are going to hear a lot about this drug class, especially for those of you who are in clinical practice. You probably know what I'm talking about. This is a drug class that the suffix ends in that glyphosate. And so you're going to get to know the brand names a lot more in clinical practice. But when you're studying in school, you want to really look at those suffixes. It's going to help you. And so in clinical practice, you're going to hear more about Invokana, Farxiga, Jardians. And so this is the drug class that now has been approved, not just in our diabetic patients, but also our heart failure patients because of that cardiorenal protective property. We're seeing great cardiorenal protective property from this drug class, and now it's been approved in our cardiac patients as well. So how it works, the pharmacology, it really decreases, again, through the kidneys, decreases that glucose absorption in the kidneys and promotes that glucose excretion. So remember, the body does that naturally with our diabetic patients, is trying to dump all that glucose out. SGLT2 inhibitors also do that. So this patient, you're going to experience a lot of increased urinary output, right? That is an expected finding. That's not a contraindication. That's not something where you're like, oh, you're increasing urination, we'll stop this medication. That is something you have to counsel your patients on because that is an expected finding. But with that, you need to really be monitoring for those yeast infections, for those UTIs, because we are getting a lot of glucose getting dumped out through the kidneys. So we really need to be monitoring for those yeast infections. So getting those urinalysis at your patient visit, educating patients on signs and symptoms of infection, when they should call or come in for an evaluation. With this drug class, I want to caution you for our geriatric patients. So we really want to make sure they have good kidneys, right? Because it's acting through the kidneys. We also want to avoid this drug class in our patients who may be at risk for infection and hypovolemia or dehydration, which is typically our geriatric patients. So what I like to do is this is the first drug class that I like to take off as my patients start to age. This is a really expensive drug class, and I don't like the side effects of dehydration and infection in my geriatric patients. So this is the first one that comes off when I'm trying to decrease their medications with their pharmacologic intervention. But we really want to watch for that, for those signs of infection and dehydration. With our GLP-1 agonists, you guys are probably really familiar with this because of all the weight loss implications. With this drug class, it also obviously first was approved in diabetics. They saw the weight loss effects and then they got it approved. They got the Wegovy and the Zepbound approved for weight loss. So this is something that you will be prescribing a lot as well, both in your diabetic patients and in your patients who qualify for weight loss. I really want to talk about the pharmacology because a lot of patients say, oh, I'll do the GLP-1 agonist, but I won't do metformin because of the GI side effects. So let's talk about the pharmacology with GLP-1 agonists. This also really works in that gastric region, right? It really slows that gastric emptying. It also works on an intracellular level. So it really stimulates the release of insulin from the beta cells, and it helps with that insulin resistance on that cellular level. And it helps with that release of that glucagon postprandially. So it decreases the patient's appetite, slows their gastric emptying. It also releases more insulin from those beta cells, and then also prevents that liver from releasing really that glucagon postprandially or after they've eaten. So in these patients, they will experience also a lot of GI side effects, also why we start low and go slow. But we also have to watch for signs of pancreatitis. This is a big one. So we really want to make sure patients are tolerating these medications. If they have any personal or family history of medullary thyroid carcinoma, this is a big contraindication, and you need to document that you've asked that before you prescribe for these patients. So do they have any personal or family history of medullary thyroid carcinoma? No. Okay, we can consider this drug class. I have had endocrinologists start patients on this drug class with different types of thyroid carcinoma that's not been medullary. I would encourage you to refer these patients to endocrinology, and they can make that assessment, just because endocrinology really manages those thyroid carcinomas. And in primary care, I personally, as a clinician, would feel more comfortable if they consulted endocrinology before starting this drug class, even if it wasn't medullary thyroid carcinoma. Just putting it out there. The other big contraindication is that delayed gastric emptying. So if patients already have delayed gastric emptying, this is a big no-no. So if they already have gastroparesis, no, I'm not going to start you on this medication. And believe me, patients have tried. We also want to talk to patients about their mood. This is not confirmed. The FDA is still investigating and evaluating reports of increased suicidal ideation with this drug class, but I tend to steer away from this drug class with my patients who do have a history of depression, just because I want to make sure we've tried other avenues before putting them on a drug class that may worsen their depression. So something to keep an eye on as the FDA continues to evaluate this drug class. Now with DPP-4 inhibitors, this is also a favorite of mine, just because I think about it, I group it in my brain as a GLP-1. So I'll tell you why. So this is the drug class with the suffix gliptins. So you have your saxagliptin, and you'll know it more by the brand names when you're in clinical practice again. But for the purpose of the boards, you can look at just the suffix and it'll help you. But these are your Januvias and your Trigentas. So the way DPP-4s work, so what is the role of a DPP-4 in the body? It inhibits the GLP-1 peptides. So if we inhibit the DPP-4, it's acting as a GLP-1 agonist, right? So then it promotes the effects of that GLP-1 activity. So if you look, that pharmacology is pretty similar to GLP-1s, right? Increases that GLP-1 activity, slows that gastric emptying. It really improves that insulin response, that glucose uptake. It decreases that postprandial glucagon excretion through the liver. So the pharmacology is very similar. So decreases the patient's appetite, slows that gastric emptying. It's really, I group it as a GLP-1 in my brain because a DPP-4 inhibitor is promoting that GLP-1 activity. It is very expensive. It's a very expensive drug class. So if you thought GLP-1s were expensive, DPP-4 inhibitors are very expensive. But if you can get the patient on it, then if you can get their insurance to approve it, great. But we're still going to be watching for those GI side effects and that pancreatitis. So similar, again, think about it like a GLP-1. We're going to be watching for that. Now, it's funny because type 1 diabetics, obviously, we don't control their type 1 diabetes with GLP-1s or DPP-4s, but it's not contraindicated for a type 1 diabetic to get a GLP-1. I've seen it, especially if they get it approved through the weight loss method, but it's contraindicated in type 1s because, again, remember, it increases the insulin response. So if patients aren't producing insulin because they don't have the beta cells, then this is not going to be a drug class that's going to help you manage their blood sugar. So it's contraindicated in those type 1s. All right. So think about what's happening with the pharmacology, and it'll really tell you those contraindications that should stick in your brain. All right, let's practice again. So this is a select all. And so for those of you who take the AMCC boards or are taking the AMCC boards, you may see some select all that apply questions. And the nice thing is they'll tell you how many are right. So I'll tell you there are 2 correct answers here, and we'll read it together. Oh, I didn't. Sorry, guys. Monday morning, a patient presents with a desire for medical management of weight loss. The patient has been working on diet and lifestyle changes, but has not had much success and is trying to improve type 2 diabetes. So which of the following diabetic drug classes may be helpful? And I'm going to do a webinar on this next month about how to break down these bigger chunk questions as well. But you always want to read that last sentence first. And I'm saying this for my students that are on this call too. We'll practice again, just the way we've been doing it. But you want to find out, what is it asking? So which of the following diabetic drug classes may be helpful? So they want you to prescribe something that's going to help what the patient wants. The patient wants medical management for weight loss, and they've already been working on diet and lifestyle, and they haven't had much success, and they're a type 2 diabetic. So which drug classes would help this patient? Is it A, B, C, or D? Is it going to be TZDs, GLP-1s, SGLT2 inhibitors, or sulfonylureas? What do you guys think? I see one person's weighing in with that GLP-1 and the SGLT2 inhibitor. What do you guys think? Yes, you guys are paying attention. Very good. Remember, with those TZDs and sulfonylureas, weight gain is going to be a potential side effect. So with this patient, they want you to help them with weight loss. We're not just talking about GLP-1s, but those SGLT2 inhibitors also help with the weight loss. Initially, it is some fluid that comes off, but then we do see some sustained weight loss with those GLP-2 inhibitors as well. Awesome job, you guys. All right, so that's what the explanation looks like. Let's talk about insulin before we jump into our case study. So with insulin, again, this is within your scope of practice. We have different types of insulin, and what I want you to be thinking about is the onset, the peak, and the duration, which sounds like a lot, but once you really are prescribing these, it does make a lot of sense. So with our types of insulin, I always like to group rapid acting and short acting in my brain, because I really think, okay, this is more of my prandial insulin. When I'm talking about mealtime, I'm going to be either thinking about rapid acting or short acting insulin for my patients. Then we have our long acting. So that's our long acting basal insulin. And look, it lasts 24 hours. It does take a little bit longer to start, about 2 to 4 hours. Doesn't really have a peak, but it does last a long time. So this is like our Lantus, where with our patients who just need a little bit of boost with their oral medications to really get them to that A1C goal. And I noticed that overall their blood glucose levels are just continually high. They're not getting a lot of peaks and troughs, but it's staying high continuously. I'm going to try to add some long acting to see if I can just bring it all down a little bit more to goal, those fasting glucose levels, right? So that's going to be our long acting. So with our rapid and our short acting, I really want you to look at the onset, because our rapid acting onset is quick. So this is going to be more in our patients. We tend to prescribe those at rapid acting in patients who like to stack insulin because they're impatient. So we get this with our type 1 diabetics a lot. They give themselves the insulin, they check their blood glucose, and it's not at their goal, so they give themselves insulin again. Now, if they're doing that with their short acting, it peaks really, it takes about 30 minutes to onset. It peaks in 2 to 4 hours. So then what ends up happening is they tank because they've given themselves too much insulin because they haven't waited it out long enough. And so what ends up happening is they tank. So for those patients, we say, please don't stack your insulin, meaning giving too quickly before it's reached its peak. And then we give them more of a rapid acting insulin because the onset's a little bit faster. So they start to see the results and they're a little happier. But you still want to be thinking about the peak. Still takes about 1 to 3 hours, depending on what type you give, about 90 minutes, an hour and a half. And it lasts about 3 to 5 hours. So you can be using these for mealtime, but you really want to give that onset and that peak enough time to work before patients start adding more insulin on, because you don't want them to become hypoglycemic. Now, with our intermediate acting, we've moved away from prescribing intermediate acting because look at this onset. So it takes 1 to 4 hours for onset, and its peak can be anywhere from 4 to 12 hours, and then its duration's anywhere from half a day to a full day. So with these patients, we get a lot of peaks and troughs. It's not this steady, okay, we're going to give a little bit with prandial, and then we're going to see the effect of it, and it's going to wane by the time the next meal and give a little bit more with the next meal. This is really labile. So with NPH, we're really trying to steer away from these intermediate acting insulins. Now for primary care, again, if you kind of group it with your short acting, rapid acting, and your long acting, think about these as your basal and then think about these as your prandial. And that's how you study them as well. I think you'll be in good shape. Let's practice the knowledge with a little practice question. We'll go to poll 9. So we'll read it together. A patient with type 2 diabetes. So this might be the way they present it, because again, remember those type 1s are going to be going to our endocrinology team to co-manage. These are our type 2 patients that will probably be considering insulin. But a patient with type 2 diabetes has been taking oral medications, but their A1C remains elevated, 9.5%. So their weight is 199. Nurse practitioner is starting insulin Lantus, and what is the correct dose that they should follow? So again, reading that last question. So the nurse practitioner will correctly dose this as which of the following, and they give you some information in that question as well. Is it A, B, C, or D? Are you going to start them on 5 units sub-Q before breakfast and at bedtime, 5 units sub-Q before each meal, 10 units sub-Q every 24 hours, or 18 units sub-Q every 24 hours? What do you guys think with this patient? Ooh, I like this. I like when you guys are debating. It makes it more fun and interesting on the teaching end. Okay. So 75% of you are saying start them on 10 units, and then about 25% are saying start them on 18 units. And that's exactly right. Those are usually the two that students come it comes down to 2, and then students are debating between those 2. Awesome. So you guys right away ruled out the 5 units before breakfast and bedtime, because you know that Lantus is your long acting, and you're not going to be giving this twice a day because you're good clinicians. Even though I see this in clinical practice, you're not going to do it, right? Because this is your basal insulin, so you're going to prescribe it once a day. That duration is 24 hours. Very good. So you're not going to be doing it at mealtime. You're not going to be doing it twice a day. Awesome job. Right off the bat, A, B, gone. Now, C and D. So D is thrown in there as a safety question, right? This is a safety question. Anytime pharmacology pops in there, I want you to think safety first. So you would never start with 18 units because that is just too high. Safety protocols. Let me go to this slide so you guys can see. Whoops, jumped too many slides. So with Lantus, yes, you can calculate how much this patient will need based on their weight. They'll eventually probably need about 18 units. But if you start them on 18 units, especially that body that's so insulin deprived, you start them on 18 units, they're going to become hypoglycemic. That risk is really high. So for safety, we would never start someone on more than 10 units a day. In our pediatric patients, we don't even go that high. But in our adult patients with type 2, 10 units a day is just, you would not start more than that. So you want to make sure that safety is always going to be top of mind when you are prescribing. Now, like I said, if you do the calculation, this patient may eventually need 18 units, but you're going to gradually increase by 1 to 2 units every 3 days. And you're going to be looking at those fasting glucose levels to make sure that we're not being too aggressive too fast. So this is really a safety question, and that's something that similarly might come up on your board's exam. So again, if any of this was kind of like too high level, we went a little too fast. I know we only have 1 hour for these webinars. I really highly encourage you to check out our Q-Bank and our on-demand videos. We have a combo package where if you guys group it together, you'll really get access to all that content. And it'll help you as you're going through the practice questions to really identify those gaps and be able to study in those areas and focus your studying in those areas where you need to improve on. We also have readiness predictors for those of you who are taking or getting ready to sit for your boards. And if you score high or very high on 4 consecutive readiness predictors, then that is our sure pass method. We always say, if you're doing about 25 to 50 questions a day, you're watching the on-demand videos and you score about 4 very high or high readiness predictors, you are ready to sit for your board's exam. And our Sure Pass and our Sure Pass Pro are really nice ways to get all that content, as well as our live review content, which really goes through all the body systems and hits those high level content. And I recommend the live review as your review a couple of weeks before your board's exam, once you've done all the studying with the on-demand videos in the Q-Bank. So okay, this is the information I need to know, I'm ready, and you feel confident walking to your board's exam. We have a Sure Pass Pro that groups in about 2 hours of mentoring for you as well. And so that's really useful for students who just don't know where to focus the studying. So this is pretty, I know our system and I know what the best way to go about customizing it for my students. Some students have struggled with that and have a hard time with that. So it's really nice to get those mentoring sessions where I can meet with you, talk to you, and make sure I'm customizing your study plan for your needs so that we're seeing the success on your readiness predictor exams. We're seeing that improvement in your test scores. So that's a really nice package and it's a really great deal. But I'm a little biased, no, teasing. And then I also wanted to make sure you guys knew you had my email information. So I'm really responsive to email. For those of you who do email me, you know that I like to get to my emails right away. And I love to help you guys decide between what boards exams to take to what content areas to go look for, X, Y, and Z. So don't hesitate to reach out to me via email as well. So I am going to now dive into our case study. For those of you who need to jump off, before we dive into our case study, I am going to release this poll so that I can gauge where your comfort level is now, having gone through the classes of medication. Do you feel like it helped you? Do you feel more comfortable prescribing now? I just want to gauge how you guys are feeling after we've gone through that content. And so I'm seeing a couple of you responding. See more people participating today. That's great. Love to see it. And you're not going to hurt my feelings if you're like, I'm the exact same. I feel like I need a lot more help. And that's okay too. That really does help me. And then if you stay for the case study at the end, I have an open text poll where you can just put in whatever feedback, comments, whatever you feel like would help you more. It's a really nice way for us to learn what you guys need and help plan our webinar schedules and our content. So I see some of you putting in the chat how you feel with 9s. That's great. All right, maybe our 10s already dropped off. I know some of you were 10 before this webinar. I hope you didn't drop down to 8 or 9. So those 10s, I hope you guys are still out there and feeling like a 10. But you guys were probably feeling like, all right, well, I've got this. So I see a lot of 8s and 9s, which is great. Great to see. All right, let's get into our case study. And I am mindful of the time because of the tech snafu. I'm going to go a little bit over today. So feel free to drop off or stay on, whatever makes you feel happy. All right, you guys. So meet John. So typically the way I made this case study is I wanted to mimic what you would see in a clinic setting. So typically when you're sitting at your computer and you're getting ready to go into a patient room, sometimes all you'll have is the patient demographics, the chief complaint, the vital signs that your medical assistant took, and their medication list. And that's pretty much it. So you'll walk in and all you'll know is you're meeting with a 52-year-old male. You're in an outpatient primary care clinic. His name is Luis Ramirez, and he's coming in for fatigue today. So pretty vague and generalized. You have his vital signs. You see his blood pressure, pulse, respiratory rates, temperature, his weight and height, and your medical assistant calculated BMI for you. Very nice. And you current medications, lisinopril, 10 milligrams. And we're thinking about that. So he already has known hypertension, but our blood pressure today, we want to definitely double check that once we're in the room. So you walk into the room and he starts talking to you. You start talking to him. You introduce yourself. You say, good morning, Mr. Ramirez. How are you today? What brings you in? So opening with that open-ended question. Mr. Ramirez says he is coming in for fatigue. You start using your old cart acronym, right? So you're asking him, when did this start? When did he notice it? So he noticed it about 6 to 8 weeks ago, so 1 to 2 months, and it's getting worse. So he reports difficulty with daily activities and also mentions that he's unintentionally lost 10 pounds over the last few months. So now what do you want to know more about Mr. Ramirez in this conversation? And I'm going to open up this poll. And this is an open text poll for our case-based learning. And you guys can put in whatever you think as we're going through this case. But what are we thinking about with Mr. Ramirez? And what else we want to know about him? Yes, I love this. So does he smoke? Very good. The 3 P's present. So break that down for me. What do you guys think? What else do we want to know about Mr. Ramirez? So we know he's been feeling tired. He's lost some weight. He's feeling worse. What else do we want to know? Polyuria, good. Polyphagia, okay. Is he eating a lot more? He's lost 10 pounds. So what about his history, you guys? Any vision problems? Any breathing issues? Okay. Polydipsia, okay. Don't worry, I can never spell these either. I'm a terrible speller. I rely on my computer. Any palpitations? Okay, so you're steering the conversation in a different way. So remember, we want to stay focused on what our patient came in for. So Mr. Ramirez is talking about he's fatigued. It's getting worse. He can't do his activities. He's lost 10 pounds. We want to dig a little bit deeper. And your ideas were great. I like those ideas, but let's stay focused too. So I'm worried about this 10 pounds. So what's going on? So appetite, I definitely want to know about his appetite. Is he eating the same amount? Is he more hungry? So somebody said polyphagia. What do his bowel movements look like? He's also 52. Has he had a colonoscopy? Does he have a family history of any types of cancer, right? With that unintentional 10-pound weight loss, I want to know what's going on. Once we've also asked those questions, we want to ask a little bit more about any associated symptoms. So we talked about his eating, his appetite. He says no appetite changes. He has been increasingly more thirsty. So he's estimating about 3 liters of water a day. That's a lot of water. right? And then he also wakes up multiple times at night to go to the bathroom. So we start to think about a whole list of differentials here, right? But then you also ask, he's not having any fevers, chills, he's not having any blood in his stool, he's not having any blood in his urine, and he's not having any pain with urination. So we're ruling out any acute issues on our list of differentials. So with that increased urination, we're thinking, does he have a UTI, an infection? With that weight loss, we want to make sure definitely, is there anything that we should be like red flags about blood in the stool? But none of that, no red flags so far. And then you're asking more of those history questions. So family history, you find out mom's a type 2 diabetic and with hypertension. She was diagnosed at 60. Dad actually had an MI at 59. So that should be a big red flag. And with the history, and I go a little bit more in depth on this when I'm talking about getting those history questions in a new product that we're building out. But you really want to make sure you're asking specific questions to your patient. So if you just ask like what any history in your mom or dad or any heart disease or diabetes, they're going to say no, because some patients really don't quantify it that way in their brain. So you want to really dig a little deeper and say, hey, like, did anybody die at an early age? Or mom and dad, do they have any heart issues in the early age? What heart issues do they have now? You really want to break it down into that simple terms. And then you also know that for his past medical history, he has hypertension, he's on lisinopril, but no previous blood sugar issues, no prior surgeries. And then his social history, he's married, he does work as a warehouse manager, his diet's high in calories and carbohydrates, soda, bread, and he rarely exercises. He was a former smoker. So kudos to you for asking about his smoking history. Quit about 5 years ago, occasional alcohol use, no illicit drug use. So now, what else are we thinking? Any other questions we have, Mr. Ramirez? And what is on your list of differentials? I want to see that. So frequent urination, any bleeding, very good. Palpitations, not a bad suggestion. You certainly, if that's the way the conversation is steering, you're thinking more cardiac. Is he having any palpitations? Metabolic syndrome, love it. Very good. Metabolic syndrome is really underdiagnosed. So I love that you guys are thinking about metabolic syndrome. You would get a random blood glucose on him. Okay. And some labs. Okay. Very good. You guys are thinking, okay, I need a little bit more diagnostic information. Love it. Very good, you guys. All right. So going back to these slides, you guys can keep typing. I love to see it. So we're going to do our physical exam. We're going to check that blood pressure again. It's staying high. We're going to also listen to his heart. So general appearance, he looks a little tired, but he's not in any acute distress. No skin findings, so no rashes, right? Think about that increased risk, that delayed wound healing. He also, you notice that slightly dry mucous membrane, so he's drinking a lot, he's urinating a lot. Heart rate, regular rate and rhythm, you're not hearing any murmurs, and no bruit. So good job checking for carotid bruit, because we are thinking about that increased cardiovascular risk, right? With his family history, with his personal history of hypertension, we're thinking of that increased family risk. So we definitely want to be listening for the carotid bruit. And then lungs are clear, abdomen, soft, non-tender, no hepatosplenomegaly. And then you also are checking neuro. So we definitely want to make sure we're asking those questions. Do any numbness or tingling in those feet or hands? Checking for those sensations are normal and intact, those reflexes in those lower extremities. Very good. So which labs are you going to order? You guys kind of already said this, and I love it, but we're really thinking about our list of differentials, right? Type 2 diabetes is top of that list. Some of you put some other diagnoses in here too, but we really want to be thinking about any thyroid dysfunction. How's his kidney function, right? Increased urination, increased thirst. I want to know about his kidney function. Could this be something like diabetes insipidus? So also want to know about his mood, depression, coronary artery disease, top of mind. And then we want to get better control of that hypertension as well. So some labs we're going to order. Some of you said this. I love it. You can do that random glucose in the office. We also want to get that chem panel, that complete metabolic panel. That's going to give you his kidney function. That's going to give you his electrolytes. It's going to give you his albumin, his protein levels. It's going to give you his liver function. So that's really great to get that comprehensive metabolic panel. Also want to get a urinalysis. So yes, we ruled out infection with those questions, but I want to make sure that this is not an infection that we're missing, right? If we miss a UTI, urinary tract infection, what happens? Patients can become septic. So we do not want to miss any kind of infection, right? If it reaches the kidneys and then reaches the bloodstream, we're in trouble. Also, CBC with that drop in weight and the fatigue, I also want to be thinking about things like anemia, right? So, what's a CBC look like? Is this obstructive sleep apnea? He's waking up in the middle of the night. We can see that on his CBC. A1C, because we're thinking diabetes, his lipid panel. Let's see what that's looking like, especially with his family history. And we're going to rule out any thyroid dysfunction. So we get his lab results back. Urinalysis does show some glucose, but it's negative in ketones and proteins. CBC's normal, chem panels fairly normal, kidney function's good, electrolytes good, albumin's good. His plasma glucose, his random glucose is high, 212. A1C comes back 8.2%, and lipid panel comes back, LDL's at 142. HDL, we can see he's not exercising, and his triglyceride level, we're seeing that diet reflected there. Thyroid looks good, we can rule that out. So what are our initial thoughts? What are we thinking about for our friend, Mr. Ramirez? What diagnoses can we confirm with these labs? And then what are we going to do for medical management? What do you guys think? So that was a lot. We kind of went through that really quickly. But we saw his lipid panels were elevated. Blood pressure's not in great control. Now we see he is diabetic, so we have to talk to him about that. What are we thinking? Yeah, he needs lipid management too, lifestyle, diet counseling. Some metformin seems like okay as a start. Love that. What else, you guys? But I think those are all great thoughts. Maybe some secondary medications, address the hypertension as a future visit, increasing that dose. Beautiful. Yeah, so Mr. Ramirez is someone we're going to be working pretty closely with, right? So I love what you said about in a future visit. So we want to break this down for Mr. Ramirez. It's going to be a lot, right? We're talking to him about a new diagnosis. We also have a lot of other things to get under control for Mr. Ramirez. So we're not going to do it all in one visit. We're going to start the conversation and see him back pretty closely. It's going to be a close follow-up for a little while with Mr. Ramirez until we get him under better control. So awesome job with that. So he does have diabetes, A1C is over 6.5%, and he's showing classic signs and symptoms, especially with those poor lifestyle choices. Definitely want to be thinking about all of that. And are we worried about his family history? Yeah, I'm a little worried about his family history, right? So the medications, someone said it, start metformin, really great option to start with. We definitely want to talk to our friend, Mr. Ramirez, about metformin, get him started on that. And then I wouldn't hesitate on increasing his lisinopril. He's been on that for a little while. He's used to it. Blood pressure is not at goal. Blood sugars are not at goal. He does have metabolic syndrome, which is increasing his cardiovascular risk. I would start him. I would increase his lisinopril and have him come back, see how we're doing with that blood pressure, see how we're tolerating the metformin. And then what else? So we're going to talk a little bit more about this next week, but let's talk about that ASCVD risk calculator, right? And for you guys, I put his risk in here, but his risk is 12.6%, even though his lipid levels, along with his LDL and HDL, were not over 200. He does have a strong family history. He's now a diabetic. He has hypertension, which is not well controlled. And he was a former smoker. So putting all that in the ASCVD risk calculator, 12.6% risk of cardiovascular event in the next 10 years. And the calculator does recommend starting him on high intensity statins, but it's definitely not something we would be starting him on along with everything else. So this is going to be multiple visits, right? The other thing I want to point out about Mr. Ramirez is that second class of medication that we consider. What do you guys think? Out of all the classes we talked about today, what would we be thinking about for that second class of medication? Immediate statin with that risk. Yes, don't want to use any drug with heart failure risk. Good. up the lisinopril, second medication, get a lipid manager on board later at least. Okay. Yeah, so you guys can absolutely decide what would you do first. Would you do the statin first? Would you do the metformin first? But don't throw everything at him at the same time. And I'll tell you about what I would do for my friend, Mr. Ramirez. But when we're talking about second agent for diabetes, so we're starting him on metformin. He's probably not going to be at goal with just metformin. What is that second agent you would start for this patient down the line in a couple of weeks when we're working with him on his diabetes? Out of all those classes we talked about today, remember something that I said has really great cardiorenal protective properties. You guys remember that? So GLP-1s will be great for weight loss. Statins are a must in this situation. So those SGLT2 inhibitors, remember they have really great cardiorenal protective properties. He has a strong family history. He's hypertensive. Now we've identified hyperlipidemia, and he's a type 2 diabetic. So remembering those complications, and I'll go to my complication side, for our diabetics, coronary artery disease, stroke, hypertension, really looking at those large, medium, large vessels, that macrovasculature. I really want to protect his heart and his arteries, right? So cardiorenal protective properties for him are going to be huge. And he's only 52, so he can tolerate the side effects of that increased urination with the SGLT2s. And we can monitor for those risks of infection. I'm not so worried about that with him, but definitely something we'll continue to monitor. But he's not our older geriatric patient population, so he's not likely going to dehydrate and get chronic infections. So I really want you guys to be thinking about those secondary agents and tailoring it to your patients on a case-by-case scenario. But for our friend, Mr. Ramirez, absolutely, we need to eventually get him on a statin, high intensity statin, metformin, get him on probably a second agent for his diabetes medication, and improve his blood pressure control. Now, this is a patient you guys talked about reinforcing those lifestyle modifications, talking to him about medication adherence and all those potential side effects, and talking about hypoglycemic awareness and all the things that come with a new diagnosis of diabetes type 2. This is a patient that I also would refer to cardiology. Given his risk factors, I absolutely want to partner with cardiology on this patient. He is at increased risk for cardiovascular complication, and this is a patient that I want cardiology to fully evaluate and make sure that we can get those SGLT2 inhibitors on board. Anything else for his cholesterol and reducing that ACVD risk is going to be really helpful. So this is absolutely a patient I would be co-managing with cardiology. So I wanted to make sure you guys thought about that and didn't feel shy to partner with clinicians in your community, especially across specialties. So again, we're going to really be monitoring for those complications in our friend, Mr. Ramirez, but you guys are thinking all the right things, so I love it. Thank you so much for all your participation today. So definitely get him checked by cards. Great idea. Hyperkalemia concern with his father's risk. So absolutely. So we definitely want to get him into cardiology. You guys were a great audience today. I am going to launch our last poll for those of you who want to let me know what content you like or any feedback about today's content. For those of you who want to scan these QR codes, this will take you straight to our SurePass Pro, which really bundles all of that wonderful content that we talked about today, including that mentoring session. I know we went over today, but you know what? I really like this content and I wanted to provide it to you guys. So kudos for you for staying on. This content does go onto our Facebook page, so make sure that you're joining our community and getting all this awesome, rich content. And those on-demand videos are really, really helpful. We also have in those on-demand videos, I haven't mentioned it yet, but we have great advanced assessment videos on there that our team members, both Annie and Morgan, have taped really high quality, and it goes through all those advanced assessment skills. So for those of you getting ready to enter clinical practice or getting ready to enter your rotations for your clinical rotations, this is really helpful. They go through everything. So head to toe exam, neuro exam, they do speculum exam, they do all of it. So how to use an otoscope, it's really great content. So make sure you check out those on-demand videos and then keep practicing those Q-Bank questions and let me know if there's anything I can do to support your learning. You guys are an awesome audience. I'm going to stay on for a few minutes just to see if I missed anything in the chat. But otherwise, have a wonderful Monday, and thanks for your patience with me and my Monday tech issues. You guys are awesome. Talk to you next time. Thank you, Tracy. You're so sweet. I hope you have a wonderful day. Thank you guys for participating. Feel free to leave a review if you go. I think if you scan the SurePass, it goes to our review page too. So feel free to leave a review about our webinars. We're still small and trying to get our name out there. So definitely don't feel shy about leaving us reviews if you're enjoying the content. And thank you for participating and joining today. You guys are awesome. Thank you, Malin. Talk to you soon. You guys are so sweet. You're making my day, you guys, on a Monday morning. Beautiful. Thank you for all the feedback, you guys. Yes, there is a recording of this webinar and it'll be in our Facebook group as well as our YouTube channel. All right, I'm going to sign off. Have a wonderful day.